So this picture you can see we have an endocervical canal which is lined by the columnar epithelium, and then we have ectocervix which is lined by the squamous epithelium. The point at which they meet is known as the squamo-columnar junction. So the original squamo-columnar junction is known as the old squamo-columnar junction, but once the baby, that is the female, she becomes mature, this cervix increases in size, and the junction, this old squamo-columnar junction, it changes its position as soon as this columnar epithelium is everted out, which is known as ectropion, and then after it gets everted out, it is exposed to the vaginal pH, and once it gets exposed to the vaginal pH, it becomes metaplastic and changes into squamous epithelium. So this forms a new squamo-columnar junction which is more towards the internal os, and the whole area between the old squamo-columnar junction and the new squamo-columnar junction is known as the transformation zone. So here is this, the most of the cervical pre-invasive and cervical cancers arise. How do we know that which is the old squamo-columnar junction? We can see through the colposcope, we can see through the Nabothian cyst. Nabothian cysts are actually the glands secretions which gets encased when the new squamous epithelium blocks them. The columnar epithelium presents at the baseline, and these secretions gets blocked, which forms the Nabothian follicles. So the terminology is used for the pre-invasive lesions. Pre-invasive lesions means a stage prior to the carcinoma of cervix. That means it is not malignant, but it is pre-malignant. So basically we use the term cervical intraepithelial neoplasia, cervical intraepithelial neoplasia, which is a pre-malignant condition of the uterine cervix. Cytologic findings are described with the term squamous intraepithelial lesion, and histologic changes are described with the term cervical intraepithelial neoplasia according to the Bethesda system. But according to the last terminology, that is lower anogenital tract terminology, this cytology as well as histology, both of them are same. That is, we call them L-cil or H-cil in cytology as well as histology, but in Bethesda classification, we on cytology we say it as L-cil, but on histology we say it as Sin1, Sin2 and Sin3, or carcinoma in situ also was a previous terminology. So now what is this Sin1, Sin2 and Sin3? Sin1 is a low grade lesion. It refers to mildly atypical cellular changes in the lower third of the epithelium. Human papilloma virus cytopathic effect, that is coilocytic atypia, is often present. That is only the 1/3 of the epithelium is affected. But Sin2 is when almost around 2/3 of the epithelium is affected. We call it as Sin2, but it is not a definite place. There is always a confusion in diagnosing Sin2. It can either become Sin1 or it can either become Sin3. So it is considered a high grade lesion. It refers to moderately atypical cellular changes confined to the basal 2/3 of the epithelium, formerly called the moderate dysplasia, with preservation of epithelial maturation. There is considerable variability in this category. I'll tell you later of markers which can differentiate it into Sin1 and Sin3. Sin3 is a high grade lesion. It refers to severely atypical cellular changes encompassing greater than 2/3 of the epithelial thickness and includes full thickness lesions. That is, therefore previous terms were severe dysplasia or carcinoma in situ. See, this is the picture where they have depicted Sin1, that is only 1/3 of the layer is affected. Sin2 is almost half of it is affected. Sin3 includes the whole epithelium to be affected. In the last system, that is lower anogenital squamous terminology, histologic cervical findings are described using the same terminology as cytologic findings. That is, Sin1 in the previous terminology is referred to as lower squamous intraepithelial lesion, that is L-cil. Sin2 is stratified according to the P16 immunostaining. If this P16 immunostaining is positive, it becomes Sin 3, if it is negative, that is specimens that are P16 negative are referred to as L-SIL, and those which are P16 positive are referred to as high grade squamous intraepithelial lesion or SIN3. So SIN3 is referred to as H-SIL according to the last terminology. So now what are the transformation zones? Squamocolumnar junction, I have already told you, this old squamocolumnar junction, and because of the growth of the squamous epithelium over the columnar epithelium, it becomes it gets shifted to another place which is known as the new squamocolumnar junction. The area in between is known as the transformation zone. So basically we have 3 types of transformation zone. To know them is important because if we get transformation zone 3, so colposcopy is almost inadequate in such transformation zones. Transformation zone 1, the new squamocolumnar junction is fully visible on the exocervix and the whole transformation zone is visible. Transformation zone 2, the new squamocolumnar junction, it is partially present in the endocervix. So actually it is not totally visible initially, but when we manipulate the cervix with instruments, then we can see the full transformation zone 2. Transformation zone 3, the new squamocolumnar junction completely recedes into the endocervix and the full transformation zone is not visible, commonly seen in postmenopausal females where the endocervix gets shifted more inside. So the new squamocolumnar junction also gets shifted inside. So what are the risk factors which people are more susceptible to cervical intraepithelial neoplasia? Infection with high risk HPV. I'll tell you in detail. HIV infection in immunocompromised situations like HIV, STDs, that is sexually transmitted infections, chlamydia, early sexual intercourse less than 16 years of age, early age of first pregnancy, too many and too frequent births, low socio-economic status, multiple sexual partners, oral pill users and smoking. So this is the picture. First, the cervical epithelium is totally normal, and once it gets infected with HPV, HPV is virus is responsible for most of the times for these pre-malignant lesions of the cervix, and it can also lead to cancer. So this HPV genome, it gets inserted and this it gets changes in interepithelial neoplasia. So in 12% of around SIN3 cases, it gets converted, it gets progressed to cancer. Although SIN1 and SIN2, only 1 to 2% of cases get progressed to cancer, that is malignancy. So we have human papilloma virus. HPV is epitheliotropic. It plays important role in the development of cervical intraepithelial neoplasia, and these cells are known as coilocytes, characterized by enlarged cells, perinuclear halo, large irregular and hyperchromatic nucleus. 90% intraepithelial neoplasia is attributed to HPV infection. Pathogenesis: infection occurs with the HPV and mostly it gets cleared in around 2 years, but wherever it persists, wherever the infection of HPV persists, it can lead to progression to cervical precancer and finally cancer, that is invasion. So cervical epithelium gets infected, that is latent or active with virus replication, but once this oncogenic HPV virus integrates to human genome, that is in H-cell lesions it integrates, and there is upregulation of viral oncoproteins, that is E6 and E7 oncoproteins, and this leads to degradation of tumor suppressor genes, that is P53 and retinoblastoma. So host cell immortalization and viral multiplication keeps on occurring, which leads to cancer or precancerous lesions. These are the types of HPV viruses. High risk are commonly 16, 18, 31, 35, 45, 52, 56, 58 and so on, and low risk are 6, 11, 40, 42, 43. 6, 11 cause genital warts, but a high risk oncogenic virus, they cause squamous or adenocarcinoma of cervix. More than 130 types of HPV are identified. Type 16 is the most oncogenic subtype in more than 50% of CA cervix cases. Type 18 is the most common in adenocarcinoma. 6 and 11 I have told you, it causes condyloma acuminata and genital warts. This is the new thing. WHO called for elimination of cervical cancer. All countries to reach less than 4 per 1 lakh women years. 90% of the girls to be fully vaccinated with HPV vaccine by 15 years of age. 70% of women screened with an effective test at 35 and 45 years of age. and 90% of women identified with cervical disease receive treatment and care. Screening modalities. How do we screen for CA cervix? Screening is very important, especially in a country like ours, where CA cervix is a very common diagnosis, most common diagnosis amongst all the gynecological malignancies. So we need to have a proper screening based modalities where we can catch this infection early and treat it on time. So we have cytology based screening, that is pap smear, and liquid based cytology, visual based testing, that is visual inspection using acetic acid and visual inspection using Lugol's iodine. This is for poor settings where we don't have adequate facilities, so we can at least see with acetic acid and Lugol's iodine, that is also known as the Schiller's test. Then finally we have HPV testing, which is being recommended these days. So this is the pap smear Bethesda system. We divide the report into ASCUS, that is atypical squamous cells of undetermined significance, and ASCH, that is exclude high grade lesions. Then we have LCIL, HCIL, that is high grade squamous intraepithelial neoplasia and squamous cell carcinoma. PAP test is successful. PAP test, although has a low sensitivity, that is around 51%, but it is a highly specific test where what we do is actually we in this picture I have shown that with the help of a speculum and Ayer's spatula. I have a picture of this Ayer's spatula. This is the Ayer's spatula and this is the cyto brush. We fit it into the endocervix and then we rotate it 360 degree so that we get the cells of the ectocervix over here, and then we can smear it on the slide and fix it with 95% of alcohol. Then this is the endocervix. We push it inside the endocervical canal and then we again rotate it by 360 degrees and put it on the slide and fix it and send it for investigation. So this is the basic cytology testing. Then we have another called as liquid based cytology. Samples are collected with the endocervical brush. The difference is that we do not make a slide, we rinse all the samples in a liquid preservative. The advantage is the unsatisfactory specimens are much lesser in number with the liquid based cytology. It leads to a uniform thin layer of diagnostic cells and we can remove the excess blood cells and mucus, and it reduces the chances of unsatisfactory samples. There is something known as auto pap screening. They use automated microscopes so that the microscope is automatically read, and if anything is found abnormal, then it is manually checked. So this I have already told you ki, this is the pap smear report, how it is given, whether it is atypical swells of undetermined significance or HCIL or ASCH or LCIL, HCIL and squamous cell carcinoma, and these are the organisms which can be determined by the pap smear, that is trichomonas, fungal organisms, bacterial vaginosis, actinomyces and herpes simplex virus. So how do we do HPV test? There is something called as self-testing also being applied these days, but we have this co-testing. Co-testing means we use HPV in combination with cervical cytology. These tests are commercially known as Aptima, Covista, Cervista, Hybrid Capture 2, and primary test, that means only HPV testing is being done, that is Cobas HPV and Quagan HPV testing. So these are, have this HPV based testing which I have already told you, and these screening guidelines are the screening should start at the age of 25 and every 5 years it should be done with primary HPV testing. When primary HPV testing is not available, then either co-testing every 5 years or cytology alone every 3 years. ACOG 2018 recommends screening to begin at 21 years regardless of sexual history, but can begin early if HPV positive or immunocompromised. FOXI and IARC, that is International Association, recommends screening to commence at 25 years. So this is for today's class. Next section will be taken in another class. Thank you.